So last time, sorry, the the recording went off. We were talking about what? We were talking about the reversible causes of dementia, and then we said the vitamin B12 deficiency is the most important reversible cause of dementia. Then we will now be talking about the assessment tool and diagnosis. There are assessment tools for the diagnosis of dementia. This includes the MMSE, the Thalamus examination, the MOCA, and the mini cognitive assessment. What are these? These are instruments used for the diagnosis. The MMSE score is the 30-point scale at which there is a questions. The doctor fill it after examining the patient, and then the higher they score, the better the mental functioning. Here you just have to know the names of the test, and there is something called clock drawing test, which is they ask the elderly to draw a test and then they assess him. 3-item recall test, they show the item, they show the elderly 3 items and then they ask him to recall it back. The research instruments, these are research used for testing and deciding on the treatment. You don't have to know it. Dementia diagnosis, we have to know that there are 3 phases of dementia: the preclinical or the asymptomatic dementia. Then we have got the symptomatic pre-dementia phase, which is the mild cognitive impairment. We said it is reversible, and then we talked about the dementia phase. There are some diagnoses being done for research purposes. This include the biomarkers of increased tau increase, decreased beta amyloid level in the cerebrospinal fluid. What are these? These are diagnoses based on the protein content of the cerebrospinal fluid, and then there are another theory that the dementia occurred due to reduced glucose uptake in the brain. Okay, these are just diagnostic for research purposes. Mainly the diagnosis of the dementia depends on the symptoms, and it depends on the MMSE score. These stages of Alzheimer's disease or the dementia include the mild stage, the moderate stage, and the severe stage. From 20 to 24, this patient is a mild, and then from 10 to 19, moderate, and then less than 10, he is a severe. So this is, you have to memorize with the numbers. So in the mild state, there will be short-term memory loss and there will be a word finding problem. In the moderate state, that the patient will not know the time and will not know the place, he will be disoriented and he will be unable to engage in the activity and the conversation. In the severe, that is the end stage, there will be a loss of speech and there will be incontinence of the bowel and bladder. Okay, you have to know 20, 24, 10 to 19, and severe. Okay, what are the management for dementia? Management of dementia include the non-pharmacological management, pharmacological management, and the herbal. The non-pharmacological management include education to the caregiver. I have to educate my patient, to communicate with the patient, to speak to him every now and then, and so on. Then we have got physical and mental exercise, and we have got avoiding, of course, of alcohol and the beer list. According to the other theories, there are non-pharmacological treatment, medical food, which is called carboxylene triglycerides. These are agent which is non-pharmacological. It provides ketone bodies to use energy when the glucose is metabolized is impaired, but it is not routinely used. Pharmacological, we have got cholinesterase inhibitor and we have got glutamic agents, and then we have got the herbal. The main pharmacological agent for dementia include cholinesterase inhibitor and glutamatergic therapy. Why do we use cholinesterase inhibitor? Because the main cause of dementia or the Alzheimer disease is what? Is the decrease in the acetylcholine. So if I am giving cholinesterase inhibitor, they will inhibit the cholinesterase. What is cholinesterase? Cholinesterase is the enzyme used for, it is the enzyme which break down the acetylcholine. So if I am stopping the enzyme which break down the acetylcholine, then I am increasing the acetylcholine in the body. What are cholinesterase products? It is donepezil, rivastigmine, and galantamine. Rivastigmine, it is available as a tablet form and as an oral as a disintegrating tablet. It is used for mild to moderate Alzheimer's disease. Here the starting point you have to memorize. The rivastigmine, it's available as a patch and it's available as oral solution and a capsule. It is used for mild to moderate and moderate to severe, and it is used when there is Alzheimer's disease along with the Parkinson's disease. The most important thing you have to know that the transdermal patch of the rivastigmine have got lesser side effects, GI side effects, than the oral solution or the oral tablet. So if in the case he is telling you that he is responding well to rivastigmine, but there is a problem of side effects, then you can switch the patient to the transdermal patch. The galantamine, it is used as a tablet, oral, and ER capsule. Remember, you have to memorize the doses. This one, it is preferred to administer with food, and renal dosage adjustment is necessary. If the patient is renally impaired and he is to get galantamine, then I have to make renal dosing. Then we have got the other agent, which is the glutamatergic therapy. It is the memantine. The most important thing of the memantine, in addition to the doses, is that it is used for moderate to severe Alzheimer's disease. We never use memantine in the mild disease. The adverse effect of cholinesterase inhibitor include nausea, vomiting, diarrhea, elevated risk of GI bleeding, then central nervous system, headache, insomnia, and dizziness, and then the cardiac, we have got the bradycardia, the hypotension, and the syncope, and the generatory, it causes incontinence. What are the adverse effects of memantine? Agitation, urinary incontinence, insomnia, diarrhea, dizziness, confusion, and headache. Treatment guideline for mild to moderate Alzheimer, I have to initiate cholinesterase inhibitor and I have to titrate it to the maintenance dose as tolerated. The moderate to severe, I have to start either cholinesterase or memantine or both of them together. Remember, don't start by combination even if it is a severe case. If it's a severe case, start by memantine, and then if you need to add it after then. And the memantine, never give it for mild cases. Generally, the duration is 3 to 6 months, okay, and generally discontinue. Then if you discontinue, don't discontinue the medication appropriately, because it can cause rebound agitation, such as withdrawal, the withdrawal symptoms. So the herbal treatment, vitamin E, it's not effective, never give it. Ginkgo biloba has not shown to be effective in prevention, and the turmeric, it's only according to the observational study. Donepezil tend to be better tolerated than other cholinesterase. The rivastigmine batch is better tolerated than the oral. Doses of cholinesterase should be titrated, and in severe case, rivastigmine or donepezil plus or minus memantine. This is just like a summary for the dementia focus point. Okay, you have got the mild, you have got the moderate, and then you have got the severe. Let's look at the case. 84-year-old widow living at home alone. She is able to perform activity of daily living and most of instrumental of activity daily living. She is taking hydrochlorothiazide, tolteridone, escitalopram, acetaminophen, calcium, vitamin D. Her MMA score is 23. What medication change is indicated? This patient is taking toluridine, okay, remember this is an anticholinergic, and her MMC is 23. 23, it means that it's mild. So are you going to add donepezil, or are you going to discontinue the anticholinergic, or are you going to add vitamin B12, or are you going to switch hydrochlorothiazide to lisinopril? If we work by exclusion, vitamin B12, he didn't mention any evidence of vitamin B12 low, so C is excluded. Switch hydrochlorothiazide to lisinopril, this has nothing to do with Alzheimer's disease, so D is excluded, and then we are left with A or B. Are you going to add donepezil? Are you going to start donepezil, or are you going to discontinue? We said that whenever he is giving you a case of dementia, try to screen the medication he is using first before starting the treatment. We know tolteridine is an anticholinergic that may cause Alzheimer's disease. It's part of the peer list, so I have to discontinue the tolteridine and assess my patient. So the answer is B. Why B? Because this tolteridone may be the causative. It is the something which is causing this mild cognitive impairment, so I have to stop it before going straight away to diagnose. 87-year-old man with Alzheimer's disease receiving rivastigmine. His family notes improvement in functional ability, but they say that he is experiencing nausea and vomiting. Which recommendation is best for this patient at this time? Are you going to advise the patient to take antacid, okay, or are you going to change the rivastigmine to batch, or are you going to discontinue rivastigmine and initiate memantine, or are you going to add prochlorperazine birectal suppository? In this case, what you have to do, you have to switch to a batch. Why? Because we said rivastigmine batch has got lesser side effects than what? Than the oral formulation. So the answer is going to be B. Case number 7, 75-year-old woman with Alzheimer disease who lives with her husband, has been treated with donepezil 10 mg. When she began therapy, her MMC score firstly was 21. Now her MMC is 17. The patient cannot perform most instrumental activity daily. About 2 months ago, her donepezil was increased to 23 mg, but she could not tolerate it and it was reduced back to 10. Her husband asked about changing her drug. Are you going to retry donepezil again, or are you going to initiate memantine, or are you going to add vitamin E, or are you going to switch her donepezil? So here the action is, first of all, we said vitamin E has got no role in Alzheimer's disease. Okay, am I going to retry donepezil again, 23 mg daily? No, because we already tried it and the patient couldn't tolerate it. Okay, so I can't get her back to the 23. So now we excluded A and C. The answer is going to be B. I have to initiate memantine because this patient is deteriorating. Her MMSE is 17, so it's a moderate, severe now. It's moderate, so I have to initiate memantine. Okay, the last topic now, we have looking at the dementia as if we want to treat what? If we want to treat the cognitive or the cognition or the cognitive impairment. But in some cases, there is cases of dementia in which the patient behavior is affected as well as it shows psychological effect or psychological symptom. Now we want to know what shall we do to the behavioral and psychological symptoms of dementia. Here he's just telling you about the progression. You don't have to memorize it. It is just the symptoms which can appear in patients with dementia include memory loss. He is maybe he is start agitation, start a psychosis, and a lot of other things. So how can we measure it? The behavioral symptom by something called MPA, Neuropsychiatric Inventory, and behavioral pathology and Alzheimer's disease, and Cohen-Mansfield Agitation Inventory. Okay, first of all, the most important thing when you are given a case of dementia with behavioral symptoms, firstly, you have to exclude any other underlying problem. If the patient is agitated, he is having a lot of symptoms, behavioral changes, then you have to assess if the patient is having a pain or not. I have to assess for medical reason and I have to treat accordingly. If found the pain is frequent issue, that patient cannot communicate, and then I have to treat with acetaminophen. So I have to exclude any other cause of agitation other than the Alzheimer's disease. If I found a pain or something, then I have to treat with acetaminophen. Remember, in any behavioral or psychological symptoms of dementia, the non-pharmacological approach is the cornerstone. Non-pharmacological is the first line. Okay, and the theory is that behavior is a communication of unmet need. That means the patient, I have to communicate my patient because I have to communicate and I have to know what is the cause. Okay, and then I have to eliminate the triggers. Okay, and I have to consider the patient-centered intervention, such as the values, the beliefs of the patients, and I have to accordingly treat. This table is showing you what to do if the patient is showing behavioral psychological symptoms of dementia. Don't worry about this because we will already come and talk about it during our course in the psychiatry, in the neurology, and so on. But now we can just mention them. Anxiety. Anxiety, if the patient is showing anxiety, we treat them with SSRI, serotonin selective reuptake inhibitor, or SNRI, or gabapentin. Apathy. Okay, I have to tell apathy is like feeling fatigue, feeling lazy. I have to give methylphenidate, which is what? Which is a stimulant. Depression, I have to treat with SSRI or mirtazapine. Insomnia, I have to give melatonin. Stay away from the diazepam. If the patient is showing paranoia, hallucination, or Paranoia and hallucination, I have to treat with antipsychotics such as risperidone, olanzapine, quetiapine, and aggression, I have nothing, but there are some drugs under investigation. Don't worry if you don't memorize this now, because as I said, we will come to talk about them in other chapters. Now, let's look at the patient case. You are evaluating the medication profile of an 87-year-old woman who resides in a secure advanced dementia unit. Her medical history includes dementia, Parkinson's disease, osteoarthritis. She needs assisting with all activity of daily living, including bathing and dressing, as well as help with her feeding. She transferred with minimal help to a wheelchair. Her medication regimen includes donepezil, memantine, carbidopa, levodopa, multivitamin supplement. The patient most recent MMSE is 5/30. It's a severe case. When reviewing the nursing note, you know that several references to the patient continuously crying out, help me, beginning around 5 p.m. She is medically evaluated and reversible cause of hypervocalization are ruled out. Are you going to begin ibuprofen, or are you going to order haloperidol as an antipsychotic, or are you going to begin music therapy, or are you going to move a patient to a private room? We said when there is a behavioral problem in a patient or Alzheimer's, I have to first of all screen for any other medical reasons. Here there is nothing to tell me that she is in pain. So A is excluded. We don't need to give her any NSAIDs. Secondly, I have to begin with non-pharmacological. Non-pharmacological here is what? Is music therapy. Why we didn't choose D? We choose to move her to a private room, because this one, it is we say that communication is very important. I can't put my patient in isolation. So here it's very important that the answer will be C. I don't tend to give antipsychotic except if the patient is showing behavioral symptoms which can harm her or can harm the people around her. So firstly, I have to screen for pain. Secondly, first line is the non-pharmacological approach. When shall I give an antipsychotic? When the patient is showing aggressive symptom toward herself or toward the people around her. So here the answer is going to be C. Patient 9, after 2 months, the patient agitation increased, such as the nursing staff cannot bath or feed her, assuming non-pharmacological approach are ineffective. Which is the best pharmacological approach? Increase donepezil, begin melatonin, add quetiapine or add citalopram. Are we going to give melatonin for sleep? No, they didn't say anything that is she is having sleep problems, so B is excluded. Are we going to increase the donepezil? No, because there is no evidence that when I am increasing the choline esterase inhibitor, it will affect her behavioral symptoms. So A is excluded. Am I going to give her citalopram as an antidepressant? No, there is no depression here. So the answer is going to be quetiapine antipsychotic. Why? Because this patient is starting to show a strange behavior toward herself. When the patient is starting to show something that it tells you that the patient is she's starting to put herself in risk. She is not feeding, she is not eating, so I have to begin the antipsychotic, which is quetiapine. So the answer is C. By this, we concluded all of the other topics in the geriatrics, and this is the end of the geriatric. Okay, I will put some revision summary of the chapter, okay, together with some questions. Go through the questions and try to answer them, and I am there. Anything if you have, just get back to me on the wall, okay, and I will be able to help. Thank you very much.